I'm Ira Kirschenbaum. I'm the editor of the Journal of Orthopedic Experience and Innovation. Tonight we have a great session, impossibly difficult knee arthroplasty. I have to be honest with you, originally started as disasterplasty, but that is a registered trademark of disasterplasty.org. And since Joey is the affiliate journal of disasterplasty.org, we decided not to, it was not wise to steal from ourselves. So we changed this to impossibly difficult knee arthroplasty, which is pretty much about the same. We are extremely fortunate to have a sponsor in Max Ortho tonight, who helped greatly to get this top faculty and panelists. We also have a number of specialists on board here who signed up to our open mic select, and I'll introduce them as the night goes on. But right now, I would like to have the faculty introduce themselves. Carl, you want to start off? Tell us who you are, where you are, and why you have a giant helmet in the background. Yeah.
Yeah, it's Lawrence Taylor.
All right, say no more.
Yeah. So, I'm Carl Becker. Originally grew up in New York. Did my training in Philadelphia at the Rothman Institute, and I do a lot of primary arthroplasty, but my specialty seems to be knee revision. A lot of people don't want to deal with some of these problems, and I think as a joint replacement specialist, we got to deal with the good and the bad. We can't just brush our patients off when things go sour. I've been doing this for 25 years now, and I really enjoy helping these patients out with complex knee problems.
That's great. Jesua Law. Did I pronounce the first name correctly?
Yeah, I go by Joshua Law. So I am an orthopedic surgeon, board certified hip and knee replacement, originally from Dallas, Texas, and then did my residency in Northern California, and then did two fellowships, one with Dr. Hoffman in Salt Lake City, and the second one with Dr. Lombardi in Columbus. My area is kind of unique to where basically there's a almost a 2 hour drive to the newest university. So essentially any very difficult either primary or revision that isn't able to make it to one of the universities comes to my hospital and eventually comes to me. So I end up doing a lot of very kind of large university style cases in my area, and also did a little bit of mission work in El Salvador through Operation Walk. And what's kind of interesting there is we end up just kind of doing what you use what you have. You don't always have all of the appropriate stuff. And then what's kind of funny is here in the town that I practice in, sometimes I'm having to do things almost like you would in El Salvador, just because some of these uh, pathologies are quite large.
That's great. That is absolutely great. Dr. Palmisano, please. Introduce yourself.
Yeah, I'm Andrew Palmisano. I'm from Ohio originally. I did my residency at University of Michigan and then my fellowship in total joint replacement at Cleveland Clinic in Ohio. I'm now practicing out in Kansas City. Interesting area. It's a pretty big city, but there's only a handful of total joint specialists out here. There's probably maybe 8 that are fellowship trained throughout the city proper, and there's probably 3, maybe 4 of us that would say that we'll do revisions. So they end up, getting funneled to us, and we're about in the 4 corners of the city. So I practice in a multi-specialty group that we have our own hospital. So it's a smaller hospital, but we're pretty specialized for orthopedics and for total joints and spine in particular. So we do a lot of big, university style cases in a small facility. Have a lot of good support around us, and I probably do 3 or 4, up to 3 or 4 knee revisions a week. I'd say on any given week we do at least 2. So quite a few of them. A lot of different infections get sent my way. Again, there's not a whole lot of people that do those, so we end up doing quite a few complex cases that patients are just grateful to get somebody that are willing to do them. They've been bounced around a lot, so it's been a fun ride. I've been out here about 9 years, so it's been good.
Great. And Dr. Miller?
Yeah, Scott Miller here, down in Florida, kind of the Space Coast is what we call it. And I'm, I've been in practice now for 10 years. I started in Long Island and then did my fellowship with the Florida Orthopedic Institute with Gusky and Bernastic and Steve Lyons. And then they wouldn't let me stay in their neighborhood, so they sent me across the state and told me to go to the opposite coast, which was nice of them. But I've been given a nice little marketplace. The Space Coast is growing and nobody wants to live here. So we've got a market of about 750,000 people and 2 fellowship trained joint surgeons. So the collecting point for everyone is me or one other person. And so we see some pretty interesting people. And, it strikes me how interesting it is to try to do major orthopedic things in small places. So community hospital, we have a 60-bed hospital, of which the majority are not for orthopedic patients. So we have to do everything in a very small space with a very small amount of things that are able to be on the shelf. So there's got to be the ability to react and to prepare like that, which was challenging in the beginning, where you come from where everything is, and it's a very different way of managing.
That's great. Couple of housekeeping issues. If you have any questions, you put them in the chat. We will call on you and you will show your video and ask the questions. I want to do start off by first sharing a screen of Dr. Law. And get that going, and we'll start off with some real-time stuff now, okay?
That's great. Okay, let's see. Click start. I'll see if I got control here. We were playing around earlier. Okay. All right, so case 1, I prepared 3 cases. All of them are disaster plasties. So first case, 83-year-old female. She has a history of a right total knee that was done in Mexico. This was over 20 years ago. Unfortunately, about 15 years ago, she had a periprosthetic fracture and also done in Mexico. Was treated with an ORIF and bone grafting. Difficulty healing the ORIF incision. They did a direct lateral incision close to the knee and had difficulty healing the incision, concerns for infection. Apparently, multiple INDs were done at that time in Mexico that eventually led to the plate removal, the bone grafting. She said she was, for the most part, uneventful. That incision finally healed. She was able to ambulate. However, here in Northern California, she fell. And I guess due to the fact that she had so many issues with her prior course, she was very scared to go to the hospital. So she ended up being wheelchair bound. Didn't tell anybody that she fell, didn't tell anybody she wasn't able to walk. And then for whatever reason, presented to the ER or the ED 4 months after a fall. Wasn't able to ambulate and has been in a wheelchair basically since her fall. Let's see here. See if I can go to the next slide. There we go. So these are her ED presentation x-rays. So you can see she's got a, looks like a PS knee, primary total knee. She's got a very small distal femoral block. And then you also have, and then a lateral condyle fracture in the middle picture there. And then you've got a chronic non-healing fracture. So you've got rounded edges, you don't have sharp edges, and then you also have an S-shaped kind of diaphyseal and meta-dia region where they had that previous ORIF, a malunion, bone grafting with some incorporation, and basically in a face of a chronic non-union. Let's see if I can go to the next slide here. Here we go. So essentially, patient presents with a chronic malunion, periprosthetic fracture. Since this is 4 months old, I didn't feel that this was something that needed to be done super emergently. So we had a little bit of time. We ran some labs, got aspirations. We ended up doing this semi urgently instead of admitting or overnight. You can see on this x-ray actually when the patient came in initially, she was seen by one of my partners who was a sports surgeon, mostly does ACLs, hasn't done a primary total joint in 10 years. He casted her, hoped it would heal, and then sent her away. And then when it was not healing, then he sent her to me. So I think by the time I saw her, she was probably somewhere closer to 6 months from her initial fall. We did get lab work and make sure that this was not infected. I did get an aspiration, and you could see a cast on this x-ray from her follow-up visit in the clinic. All right. So I don't know if we wanted to pause here and kind of talk through it, or do you want me to just keep going and show what I did?
Let me see, does anyone have any questions they want to kind of blurt out? Any options out there? I don't want to embarrass anybody in calling them, but what do some people think? If not, or not.
So workup for chronic osteomyelitis, what we did is we did infection lab work, which came back completely negative, and then we did an aspiration of the knee. I believe we had an MRI, which also showed all of this was a CT and an MRI, which unfortunately I did not provide, and I apologize for that, but it showed that this was all cold. There was no signs of any kind of sequestration or involucrum. There was no signs of inflammation inside the knee area. This was all very cold and there was nothing that was lighting up there.
No,
It's a great.
let's go on next. What'd you do, young man?
Yeah, so somebody on here said thinking distal femoral replacement. Absolutely. So that's one of the things that we were thinking about. However, due to the fact that we had such a large segment, and I'm going to go back one slide.
Yep.
Let me. We had such a large segment of this S-shaped malunion that the distal femoral replacement would have to have been brought so proximal into the subtrach region that I was a little bit concerned about doing just a straight distal femoral replacement. So what I opted for was actually an intermedullary total femoral replacement. It's honestly, if you're very familiar, or if you're familiar with a distal femoral replacement, it's very similar. So I'll get to, let's see, we'll get to my slide here. So what this is essentially it's a distal femoral replacement on the distal end, and then it has an attachment point for a proximal femoral component. So this is the Zimmer Biomet distal femoral replacement. So at the top, it mates with an Arcos stem. The reason I decided to do this is I knew to get fixation, I needed to come so proximal. So I was going to be in the subtroch region. And I do have a patient that was done by one of my colleagues. He did a distal femoral replacement. And then what happens if you get a femoral neck fracture or they develop arthritis? Then you're kind of hosed. I can't get a stem in that small little segment there and get fixation. I've had to do that before, and it's a disaster. It's another disaster plasty. You're kind of trying to make something up, and I ended up um, making something up. It worked okay, but I think the more appropriate thing when you need a stem that's going to go that high for my thoughts are a intermedullary total femoral replacement. The amount of dissection is very similar to a distal femoral replacement. It just gives me the option later on to where if she ever fractures, develops arthritis, I can just pop on a an Arcos proximal body and you're ready to go. And if it's, a femoral neck fracture, I could just do a hemi, or if she develops arthritis, I can convert this to a total hip very easily. Some kind of technical pearls that I like to discuss is the screw at the top. I left that there so that way that wouldn't get overgrown with either cement during the cementing process or overgrown with bone. I also placed bone wax on the top. So that way, if I ever have to come up to the come back, I would basically do an ETO of the proximal segment, find that screw, just remove the bone wax, and then start mating that with an Arcos proximal body. Other points that you want to do. I don't know if it's giving me control. Can we go back one slide? I'm sorry, Eric.
Sure, absolutely. Gotcha.
one of the other points is that you want to do is just kind of make sure you're taking measurements of the total femur before you do the procedure and making sure that you leave enough room proximally. So if the system that you use, this system is a Arcos. So the smallest one is a 50 millimeter proximal body. So I have to make sure I've got at least 50 millimeters up top proximally. So that way, if I do come back, let's say with a femoral neck fracture, I perform the ETO and then pop on a 50 millimeter proximal body, cable the greater trochanter back on. So I just need to make sure that I've got at least 50 millimeters. So that was the reason. Total femur, intermedullary total femur versus distal femoral replacement is I had to go so proximal. She is a shorter Hispanic woman. So just making sure that we had enough room was something that you wanted to be aware of. Also, another technical pearl is you'll notice the cable whenever you're doing one of these distal femoral replacements, or in this case, intermedullary total femoral replacements. I do recommend. I believe it's a technique pearl. You want a cable before you ream, just so that way you don't accidentally crack something and then propagate a split, and then you start chasing your tail. So that cable is a super cable that was placed prior to reaming, and then you just ream and then cement. I did leave the cement, made a cement collar distally, just for the fact that I used antibiotic cement and I wanted something that would elute antibiotics long term. All infectious lab work was negative, but I just wanted to leave some type of a drug, antibiotic delivery drug device in there with the cement. So I left a little collar of cement distally.
That's great. If anyone has any comments, I'm going to move on to another surgeon, then go back to you. Okay, Jesua?
Yeah.
Okay.
Can I ask a quick question about that one?
Yeah, sure. Quick question. Go ahead.
What's the fixation like on that proximal aspect of the stem? Those intercalaries are usually smooth bored, right? Or is it cemented or scratch fit up?
It's got almost like a porosity, so it's a grit blasted stem that has a little bit of a bow to it, and then I did cement it in. So what I did is to make sure that I didn't have cement interdigitate with that proximal body, I placed bone wax all around the proximal body, and then placed the proximal most extent of it into the femur, and then used a cement gun around it, and then kind of integrated, push that grit blasting and cement into the femur, and then built the collar around it. So it is grit blasted with cement.
Thanks.
Yeah, absolutely.
Great. I'm just admitting somebody here right now. Scott, you're up. If you're available, Scott Noah.
Present, yeah.
All right. I'll move you along.
Yeah. So this is a case about what do you do when you're not ready, right? We all work in small hospitals, and sometimes the obvious stuff feels wrong. And so what I have come across in my current marketplace is a pretty extensive past placement of a recalled device. So the surgeons that were in the market prior to me implanted somewhere in excess of 6,000 implants over the course of 15 years that got recalled recently. And they both retired conveniently. So what we're getting is a lot of this type of case. And this was somewhat early on. But basically, they all come in roughly the same way. So it's a relatively young guy. He's 67. He's super active. He's got a well-functioning right knee replacement with mild pain that he's told was relatively normal. He plays golf 5 days a week still, but he does have soreness. And since he's recently got his left knee fixed, he's like, man, things seem to be getting worse. And so I'm going to the next slide. This is where he was 2 years prior to coming in and seeing me with pain. It looks, arguably relatively fine. All right, it can mark out that he's had a knee replacement, nothing terribly obviously inappropriate about it. So let's go to the next slide. So when he comes in now at his 9-year post-op visit, his knee looks just a little bit different. But again, in my mind, the terribleness of it was, his poly is starting to wear out. I start to see this undermining on the tibial side. We've got a little bit of perhaps undermining at the posterior condyles. And his patella looks a little off as well. and we know it's recalled. And so my team had saw him originally. We go to the next slide. They get a bone scan in most of these patients and a workup with the inflammatory markers. We see that his knee's lighting up. He's got a recalled implant. So we go in there with the intention of revising. So let's go on to the next one. Do we see problems? Like, do people look at this and go, yeah, relatively easy, definitely taking it all out? Where do people stand on this type of thing? Because this is the type of implant and this is the type of revision that even community guys are going to see and things look pretty direct. What do you think, Carl? You seen a lot of stuff like this up there?
Yeah, and it's always worse than what you think it is. You
Right
get in
about
there
that.
and you think it's going to come out pretty easily. You're not going to have that much bone loss, and then you get in there, and it's always worse than what you think it's going to be.
You're
So-
right. I agree. And my experience so far in this particular type of revision is that they do come out relatively easily because there's almost no connection between the implant and what remains of the cement mantle.
Yeah, these you just pull out with your fingers.
Right, but the bone loss is so substantial, and that creates a secondary problem. So let's jump ahead. So we bring this guy into the operating room with the intention of revising. But when we take his implant off, what you can see in the femoral side here is that he has virtually no bone. So from his patella proximally to the extent of that cement piece, there's nothing anterior and there's nothing end-L. So he's just got a hole all the way up. His whole femur is missing. Now, here's where things have gotten somewhat complicated for us here. In a patient subset that has normal inflammatory markers and normal infection workup, we would think relatively safe to proceed with the revision arthroplasty straight away. But my current experience is finding almost 20% of these patients have some latent infection that'll grow out of more than 2 cultures by 2-week mark with no rhyme or reason for it. Now, when we have nothing to build off of, and we have a gentleman that's quite young and very active, we have, I think, a little bit of a challenge in how you go about the reconstruction process. The obvious answer, if this guy's 15 years older, I think, is to do a distal femoral replacement and let him get up and walk. That's a relatively simple surgery that I think you could get by with. However, in a 67-year-old that's golfing 5 days a week and the longevity of a distal femoral replacement probably distinctly less than his lifespan, I was trying to figure out what kind of options do we have. So anybody, Andy, what are you thinking? Andrew, what are you thinking about this?
I mean, I think it depends on, like you said, you're missing the M to L, bone when you're looking at the distal femur. So how likely is it that the condyles are going to hold? And if they're holding your ligaments, then can you use some type of, not just augments, but use a cone, use something to try to get some fixation. But I mean, honestly, looking at your cement there, I mean, it doesn't looks like you're going to be pretty high up to try to get any fixation in the metaphyseal region, and you're going to be kind of the metadiaphyseal region. So, I mean, that's what I would be looking for is, well, how much bone is there? Can you get anything to actually hold? And then you can do, you can do a hinge. But again, I mean, you're running into the same kind of problems. But I think it all kind of hinges, or it all depends on your condyles. And do you have a connection still?
Sure. So looking, I mean, as you can see on that AP, that cement goes right up and that bone stays right there. So my thoughts at the time were that the collaterals were present, but the amount of bone loss was so substantial. So I did go forward. I tried to do a hinge here with the same ideas, right? I tried to get fixation with a cone first off. That was my primary target. But the hinge size plus the offset needed to get a long enough stem of the femur, I couldn't get a cone big enough in what remained of the femur to get there. So actually what we did is we took Marlex mesh and we sewed it to the periosteum across the front to kind of create a barrier. And you can actually see that there's a hole proximal most of the distance between the proximal portion of the femoral component and that cable. And that's all covered with mesh from side to side. And the cement actually pushed up against the mesh and kind of created a little bit of a compressive action at the bottom. So, while it is an unideal situation, my patient's 2 years out and continues to golf now 3 days a week. He's got a little bit of a fatigue problem just because of the amount of time that went into it. And again, trying to get fixation, you can see how that lateral shows that the clothespin of that femoral stem has kind of compressed a little bit. So you've got some reasonable fixation outside of the cement there. But these are the kind of cases that you can really get in trouble with for two parts. First, you don't know how to get fixation and how to stay stable. And that's distinctly a challenge. I thought I've used that mesh technique now on more than one occasion to try to give me some sort of barrier for cement. And then
that was anesthesia, actually.
That was anesthesia. And then a secondary and more interesting thing I found is the latent infections that I've been, and these aren't regular infections. I'm not finding staph or strep. I'm finding salmonella and mycobacterium and some really peculiar bacteria out of these cases. And I found that if I'm going to put this much implant into a patient that then turns out to have an infection, I've missed the boat on treating it. And so what I've been working on is these guys stay in the hospital for a week. They get a high dose pan antibiotic spacer on IV antibiotics, and I treat them that way. It's more challenging and a little bit time consuming in the hospital setting, but that number, when it all comes down, is going to be pretty significant.
Yeah.
All right. Sorry about that before Cujo went nuts here. I'm just looking at this, and again, similar principles with what Josh said. It looks like you put, I don't know if the cable's there to prevent with the reaming or to help with the mesh, but again, a lot of times we do put prophylactic cables on if we're reaming and stuff. The other thing you'll notice, you can already see there is that thin piece of bone laterally looks like it fractured. So I think if you try to do a regular implant without the hinge, you would be coming back again just because that bone is too thin. And I think the other thing you mentioned with the cones is, everyone asks like, how come you don't use so many cones? I was like, for me, I think a lot of the cones on the market, they're almost too big to use a lot of the time. And then you're in this quandary. Do I put the cone in to get better fixation at the expense of removing native bone, or I just fill it in with cement and keep as much native bone as possible? And that's something else I've come across a bunch of times with the cones.
Absolutely. And that cable is the proximal or the distal-most extent of where anterior femoral bone was. So that was essentially what it was like a half moon shape because the anterior was gone and there was still something around the edges. So I was trying, as Jesua mentioned, not to propagate by doing something stupid. And that stem it maybe doesn't look tight, but for his anatomy and what I was doing, there was a forceful impaction to get that thing to go where it was supposed to. And it's challenging to figure out where it's supposed to stop because I didn't have any bone to guesstimate at. I had to measure where the trial sat in relation to that cable and try to hammer to the same point.
Interesting. John Sullivan, you had a comment about cones. Do you want to yourself, and would you find some cones for this type of case, John?
Recently I've been doing, at least for the tibias for sure. I probably would have tried it on the femur, but just because that's a lot of cement, but I'm not saying you're wrong. It looks great. For the tibias, I found that a lot of times when you're cementing over and over again into the tibias, I just find that they resorb a lot proximally in the proximal tibia. And so I found where you get it doesn't even have to be a big cone, even in one of the smaller cones. I find that you get a little bit of ingrowth, between that and the cement proximally. I just find that I get better survivorship in those. I don't know what everyone else thinks.
I totally agree with you. I actually use cemented tibial. I use cones for almost all of my tibial revisions, specifically because I like. Oftentimes there's that big hole, and you've got to figure out how to get your fins right, and you can use those cones to help with that. I actually tried 3 different cones from 2 different manufacturers on the femoral side, and could not get a cone to sit that allowed the stem to get in the right size. So I tried a bicondylar cone because that seemed to make sense. And then I tried a central cone. Then I tried a small central cone with a stacked one underneath it, trying to give me something to build off of. I find that with the hinges, that tibial side is pretty robust, and the fins for this particular one are pretty rigid. So I didn't use it on that occasion, but I agree with you. For the most part, I use tibial cones universally.
Any other comments on that? That's a yet another staggering case. Let me just see. Here we go. Andrew, this is you?
Yeah, you got it.
All
Let me see if I
right.
can. All right. So obviously this is not a revision case, but ends up being kind of an interesting one. So 53-year-old guy, so a pretty young guy, came into my clinic walking on this knee. So, it's obviously got some interesting backstory to it. You can see quite a bit of swelling and everything there. So talking to the guy, he's been living in a facility for quite some time. He's got, to add another wrinkle to it, he's got schizophrenia. And so he's been kind of bounced around a lot. So over the last 10 years, he's been getting aspirated pretty regularly for fluid. Never been checked out that he knows for infection or anything. And so, he comes with these x-rays on the left, and you start to think, okay, well, something, went south at some point along the line. So I aspirated him, quite a bit of fluid. I got, I think like 180 cc's of fluid. It was pretty turbid, but it didn't look, it wasn't straight purulent. Obviously came back infected. It was I forget the exact bug, but it was a very odd bug that I hadn't heard of before. So I got my infectious disease colleagues to help me. But, when you're looking at that x-ray, then you start to think, well, what are you going to do with this? It's obviously infected. So, you've got to do something. So I did an antibiotic spacer, but the bigger issue, or what I was kind of thinking, is he had quite a bit of instability, preoperatively, which I think was mainly falling into the hole that he had. And I'll show some intraoperative pictures of some of the bone loss. But you start to think, okay, well, how are you going to manage this? How are you going to get fixation? So, the antibiotic spacer that we put in, they were pre-molded spacers. Did that for 6 weeks, IV antibiotics, and then came back and did our primary. And you can see from the tibia, big bone loss just scooped out of there. And so this is, you can see I didn't clean any of this bone or anything. This is how it looked. So, big, wide open space all the way down. So now you're starting to think, and, we'll obviously talk about the cone, but starting to think, well, what are you going to do? Something that I had to think of before going in was, I anticipated there's going to be quite a bit of bone loss. And I had the luxury then of having a 2-stage. So going in, I could see that there was that much bone that was missing in the tibia. So I don't normally stock these perimeter cones. I use a lot of just central cones, smaller ones. So that's something that, again, I don't have these things sitting on the shelf. So I had to make sure, find cones that would fit, measure, to make sure that we had those. Otherwise, the amount of cement that you would use would just be ridiculous. So, so once I got the infection kind of underhand, then we went back, did this perimeter cone, which fit pretty nicely. I used a burr to take away some of the bone in the posterior aspect. So I didn't have to take away that much, but you can kind of see on the left, there's a little cleft of bone here. So I was able to, use a burr to kind of make this fit a little bit better. Once we have that in place, then, a little bit easier to kind of to take care of. Let me go. So after that, we were able to do just a standard, PCK or condylar constrained knee, and ended up, handling fine. You can see still in the tibia, it was just wide open all the way down. So, I did a fully cemented because the large, diameter that he had, there was no bone whatsoever. So doing any type of press fit, you'd be well down in the diaphysis. So he's about three. I think he's about three. I want to say about 3 years out now. And to be honest with you, he followed up initially. He's in a home and hasn't made it back in the last 2 years. But he had been doing very well at that point, walking around. He was very happy with it at this point. And it healed up uneventfully. But the biggest concern that I had, going into it originally, if I can, let me see if I can make it go back, was, essentially when somebody walks in with this x-ray, that's when you start to think, okay, there's clearly more to this. There's clearly an infection. Are you going to be able to manage this, to get the infection taken care of? And how well is this bone going to be to hold the collaterals? So that was a big concern of mine. His ended up being okay. That's not always the case. So similar to Scott's case, if some of this bone, which you can kind of see is missing around here, and that condyle breaks off, you're looking at a whole different world. So, I don't keep, all of these at the hospital. So you got to keep, or for these cases, you need to make sure that you bring in, all the different implants that you may need. So bringing in hinges, you don't necessarily need distal femurs every time, but to have a hinged component, if you go back in and the condyles are broken off, I had a little bit of time to kind of prep for this because we went in and did a spacer the first time, but it was pretty interesting. I mean, the reason I wanted to bring this case up is, the amount of bone loss. I got to say, I've never seen one that has zero, bone except for the cortex, all the way down. I mean, you could look down all the way through his tibia from the top. So a little bit interesting to kind of manage, but once you take care of that and you get some type of fixation with that cone, I mean, honestly, then it almost becomes, not necessarily a primary, but a pretty straightforward revision. So, yeah, there's a couple questions, I think.
Yeah. So Andrew, my question was sort of about like, what do you do with the patella when you're treating native septic arthritis in terms of the approach to, are you doing a primary resurfacing of it when you put your spacer in? I've had this debate and done both things, scraped the cartilage off, and then just done a resurfacing from doing like a low friction articulating spacer. Curious what you guys are doing.
Yeah, I mean, obviously this is not a very common scenario, but I've done it several times, and I just, similar to what you said, I plan to resurface it. So I cut basically the cartilage off with the saw and leave it, just underneath the cartilage. So leave it as thick as I possibly can, knowing I'm going to come back in and smooth that up. So, you want to make sure you get all the cartilage, obviously, but yeah, I mean, I think you could put a little cement cap on it, or you could do, something. I wouldn't cement the implant in at that time or leave the cartilage. So I think you either got to scrape it off, like you said, or I usually just cut it as shallow as I can.
Yeah. So it's a fascinating case, and I'm going to switch gears just slightly. Is there another question I missed, or I just want to make sure? Scott, you had a question on this one, or I'm not sure. All right, I'm going to switch gears a little bit, and because these are three remarkable cases and incredibly impossible, difficult cases. Let's talk about your approaches to your career and saying, how do I set up my home base? We have the fortunately, I'm gonna see if I could put a couple of people on the spot. Um, I don't know. Is Eric Smith still on? Eric, are you on? I don't see him
I'm
there.
right, they just dropped off.
Oh,
just to
okay. I just want to know, let's go one at a time. Jesua, what do you do to knowing you're going to do 2 or 3 of these a week or 4 a week? What do you do? What does a surgeon do to set up their OR for this? Set up their life so it's not a miserable hell.
I think honestly, as much planning as possible. One of the things that we would always harp on in fellowship is, especially with the revision, it's a lot about making sure you've got plan A, plan B, plan C. And exactly what was highlighted here is many times you get in there and you're just like, oh crap, I got to go bigger and I might need more. So I think with a revision, more options, more plans are always better. And then make sure you can move seamlessly throughout the plans. And then sometimes when you just get in there, you also have to, one of your plans has to be, what if I got to bail? So if I just don't have what I need, if it's not going in a good direction, sometimes you have to bail and find a way to safely put something in that'll stabilize the knee, and be able to get out, get some more information, figure out what you need, what you want to do, and then come back to fight another day, which I think we've demonstrated. You sometimes have to do that. So having that as one of your plans and being able to plan appropriately, I think is the best.
Right. Anyone else? Call?
Well, I think what I usually try to do with the revisions is do them later in the day. If you have routine primaries and stuff like that, you bang out the routine primaries and they do the revision. You like doing the revision in the last case, because if you get into trouble, you don't have the pressure of 4 or 5 other patients waiting to do stuff. Those patients are done, and you get into a little trouble. It takes a little bit longer. You don't have that extra stress of other families or other patients, like, when am I going to get done? When am I going to do this? So I tend to do them at the end of the day, just so I don't mess up anybody else's time.
That's right. And what do we think about, in community hospitals versus tertiary centers? As you start doing more and more, what about the idea of consignment and what you really can keep on the shelves?
Yeah, I think that's my problem. So I essentially I have one type of primary I can use, and I have space for one revision that I can keep in house. So I essentially have the one revision opportunity that I can use as state, and my backup at all times is a spacer. And if I need to, I can always push to a spacer and figure out a better opportunity, because there's going to be that guy that you think you've got it in you to put in a primary PCK, and then something tragic happens and you need a distal femur. And right. You don't have the room for the 26 trays that the distal femur takes up, or the Smith and Nephew hinge, or whatever it happens to be that you use. That's not my opportunity. And in the state of Florida and in my local community, that's not even an option. I have to give them knowledge ahead of time that I'm going to use it. And once they come in for those small surgical hospitals, it's expensive to process all those trays.
Yeah.
It's hundreds, even thousands of dollars to process the distal femur trays to get ready to then not use and send it back out. So you have to be really cognizant of that you'll burn people out. And then all of a sudden, when you need something, it's not available, right? I mean, we've all, maybe you haven't, but I've come across a point where they say, sorry, you can't have that this week. What? What am I supposed to do now?
Absolutely. Any other comments from anyone about setting up their OR to be a surgeon who does difficult revisions? Yeah, go ahead. Sorry. Go ahead, Andrew.
I think an additional comment kind of to what was already brought up is you want to make sure that you plan as best as you can and have everything available. But something that Scott was just talking about is if you have too much, you try to bring too much every time, and if you are worried, well, okay, I need to have a distal femur at every one of these, then that's when, again, you burn out your SPD, you burn out your staff in the room, the reps, everybody. And if you don't need that and you don't use that, it can be, a comfort for you, but you've got to start to kind of, pick up what do you feel comfortable with? How do you think you can manage these with, short stems, or do you need long stems, or what are you going to need? Because you can't have everything available at some of these places. So, I mean, I don't have room to have anything. We have to bring it all in. So it's, 20 totes for some of these, some of these cases. And I mean, it burns people out. So you've got to make sure that you've got your plans, but you also have to feel comfortable with, and it comes with doing more cases, but you got to feel comfortable with what your plan A and B are. You can have plan C or have other ideas, but again, I mean, it may end up being that you have to kind of bail or do something, a little bit different, because you can't have everything available. Especially cones. I mean, all the different sizes. I mean, there's so much that you could have. And I mean, I, trained at Cleveland Clinic when we had a machine shop in the basement that would literally make implants and then sterilize them, and we could put them in. And a little bit different when I work at a 10-bed hospital. Yeah, we don't have the room for all of this. So just something to think about, that you can't always have everything available.
No, absolutely. And also, it's very interesting. I have found over the years that there are, of course, the impossibly difficult knees, but every once in a while you get the regularly impossible knees, not the absolutely impossible knees. And many of them can be managed with surgical skill and, what I call a primary revision system, something like, the Freedom PCK revision system that has, a variety of versions of a variety of stems. Does a lot of your practices have a lot of these almost impossible, you know, type of cases? I was going to show one, for example. This was an old case that I had. Um, I'm gonna share my whole screen for a second. Okay, hold on. There we go. There we go. So can you see my screen at this case?
We see something that says, "Surgeons, please fill out the form tonight."
Oh, you don't see that, huh? Oh, it's paused. Sorry. Share. How about now?
No,
No,
sir.
we
not
still
yet.
see the
That's good.
other
Okay, let me
form.
try one more time for fun. Okay. How about now?
Yeah, we see it now.
That lateral. Okay. This guy came into my office horribly walking. Okay. And then I'm going to stop that and I'm going to share this other one, which was his AP. Okay. And stuff like that. Um, but was very interesting. So how would you handle this, Dr. Law? You're looking at this. This is sliding back. He's kind of pretty varus in there, you
Yeah.
know.
Yeah, so I would do I'd definitely, my primary plan would be a primary PCK. I would go in with a primary PCK type of component
Yep.
with the full bore CCK on backup. So I would be one of those two things, and then I would have a cone available. I think if I can get a long stem in the tibia, I would be comfortable using a rebar technique, long stem on the tibia, and probably not using a cone. But I would have a low threshold to basically use a cone. That there's a lot of bone loss on that medial side, so I actually might be leaning a little bit more towards a cone. But I mean, definitely stem on the tibia, stem on the femur could be argued, depending on how much constraint. Usually, if I go above a mid-level constraint, then I stem both components. But if I can do a mid-level constraint, I usually get away with just stemming one component or not even stemming a component.
Interesting. I got to show you, embarrassingly, my post-op. There it is.
Yeah, it looks fantastic.
Yeah, it's funny. I didn't even need a constrained poly on that. It just his ligaments were actually much better than expected. You
Yeah.
know, I came in with the kitchen sink all the way to a hinge, all the way to a hinge. And I was
For a
like,
lot of patients like these, and I think that's something that maybe working more, you get a lot of robotic minded patients in my Space Coast area. And there's been perhaps a shift away from that directly down the middle sort of idea on alignment. And you could put a knee like that in a fairly significant amount of varus. You could cut that tibia in a pretty large amount of varus, and you might find for that I would plan for an ultra congruent, just like you, a non-constrained knee with the intention of cutting and then releasing. And I find that the more you can kind of commit to the idea that the tibia doesn't have to be straight down on your x-rays,
yeah,
and the more you can be comfortable. And that's definitely something I've seen more as I see real-time numbers in the robotic setting, like 5 degrees of varus on the tibia has exceptional survivorship, and it changes the need for releases and perhaps the amount of constraint that you might be anticipating. So I would go with the same thing. And that's, within the system that I use, I admittedly do go with the Freedom system, and it has a lot of scalability to it. It's got the straight up system that then you can add stems to, and from the stems you can go in, and each step kind of all comes within the same kind of system, which allows for moving up and down in complexity pretty easy. It allows us to keep one system in place without having a lot of different stuff.
It's great. Malik, you had a question, Malik, about exposure? If you want to ask it. Otherwise, let's talk just finally about exposure on these cases. How often do you perform osteotomy, a turn down? Let's go through the faculty a little bit. Andrew, what's your approach to exposure on some of these very difficult cases?
I mean, I guess early on in my career, I would do, like a VY turn down or some type of advancement, proximal extensor mechanism, releases. But I mean, honestly, as far as tubercle osteotomies go, I don't think maybe it's seen me, but I haven't seen it type thing, but I haven't needed to do that. A lot of these, like I said, you can kind of deal with the proximal, aspect or the quadriceps tendon, but I mean, I got to be honest, I probably haven't done any of those, a SNP or VY or anything. And I mean, several hundred revisions. I mean, I've been able to, kind of use some of the retractors, kind of go slowly with it, get things to kind of loosen up. I always release any scar or fat pad that's still left first, off the distal aspect of the patella, which often, gives a little bit more. I'll also release the attachments, kind of do a partial kind of, I guess, inside out lateral release right off the patella laterally to try to, let that flip a little bit more, give me a little bit more movement with it. But, I've got a lateral retractor that I use that I kind of will put a little tension on the extensor mechanism to see if I can get that out of the way. But I think, if you go slow with it, I have a new PA now that is a 25-year-old 6'6" man that is a little bit eager, and he today we were doing a revision, or yesterday we were doing maybe it was today, long day, and he put a little bit extra umph on it and started peeling off some of the tendon. So I go slow with it and try to see, but yeah, I mean, you can always do, a VY, or you can do a quad SNP. Quad SNP, I used to do a bit more, and I wouldn't change my postoperative protocol. But as far as tubercle osteotomies, I would try to avoid that just for the ramifications of your post-op course.
Any other comments on exposure?
Yeah, I think maybe Jesua could speak more to it just from the directness. But in my fellowship, I worked with Steve Lyons and Ken Gusky, both of which had a fairly significant relationship with Hoffman and that banana peel type technique for patellar tendon. You can kind of create a sleeve and almost peel that thing straight off and sew it straight back to the medial sleeve if you've got two pretty good sleeves. They come together fine without a lot of consideration. I think the only time I've used a tubercle osteotomy was in that 150 millimeter stem that somebody came in and hammered as far down as they could. And even then you might be able to argue that, resecting extra distal femur creates more space, and you probably, Carl talks about this occasionally, if you're not augmenting your distal femur, you probably didn't do something right, or something to that effect. I forget the exact version of it, but I listened to the conversation. I was like, well, it's not wrong. So you can use bone cuts to make space. And I don't flip the patella. I tend to either just move it to the side or kind of peel it off a little bit until a point where I can get that space in my availability. And I haven't done a VY or a snip or anything of that nature, I don't think, in a very long time.
Yeah, I think one of the things that wasn't really highlighted is it's very important that you don't try to do these minimally invasive. Be generous with your skin incision. A lot of times, if you go proximally, you can get enough excursion with the lateral side and get your exposure as long as you're going proximal. Sometimes even just with a standard medial patellar approach is, I think, what Dr. Palmisano was talking about. For me, I do go proximal and I just quad snip everybody because it's shown that there's no difference in outcomes, no difference in pain scores, and you get so much more improved exposure with a quad snip. So I go proximal, quad snip pretty much almost all of my revisions, and I usually do not have to do a banana peel. But if I do, the first thing that you have to do for a banana peel is a quad snip. So if I do, I just end up doing the banana peel. I do recommend, if that's something you're interested in, make sure you read Hoffman's paper, because I think a lot of people will accidentally, inadvertently rip off the patellar tendon. They're like, oh, that's a banana peel. There's a certain technique to doing it and doing it correctly to have the good results. And in fellowship, we actually did a banana peel after a TTO a few times, and that still had good results. And we wrote that paper up. So that's a great and very powerful technique to do and to know how to do well. But just make sure you're doing it as described, and ripping the whole tendon off is not a banana peel, which I've seen people do in my area.
Well, many people can attest to this is the fastest hour in orthopedics. I know some of you could do 3 or 4 primaries. If Charlie DeCook was on, he'd do 3 or 4 primaries by 9 o'clock. I do want to share one picture as a chairman of a department that's a little cost conscious at time. We were using so many cones that I really kind of came up with this picture to show my attendings the only real use of the cone. And I felt that this was probably the only realistic use of the cone, and that maybe they should consider some cheaper options. But those of you who are cone crazy, it's taken the world by storm. We know that, and has solved a lot of problems for us. I want each of the faculty members to summarize a little bit, and just a couple of take-home messages. Dr. Law, we'll start with you. You're on, and a couple of take-home messages of people who want to start or increase their skill on taking on these impossibly difficult cases.
Yeah, I would say just make sure you start with the basics and make sure that you've got good exposure. I mean, honestly, if you can get really good exposure and you can get everywhere you need to in the knee ends up coming apart and coming back together very well. I think a lot of times where I'm seeing people struggle is they don't get the exposure. So I would start with getting a really good exposure, being very comfortable with exposure, and then just work through the approach of getting a good exposure. Then how am I going to get my implants sticking onto the bone? And then lastly, how do I balance? And I think if you just kind of work through it in that way, I think pretty much even the disastroplasties you can start working through those options very well and logically.
Great. Dr. Miller, you want to say a few comments before we hang up for
Sure.
today?
One of the first times I was left to my own devices to do a revision, the person's like, give yourself allotted times to do the tasks that are necessary. And so, the first person that told me that was actually for a calcaneus, right? You've got the approach, you've got the exposure, the fixation, and the closure. And I think the same thing goes if you divide up your revision experience into no more than 30-minute blocks. You can say, all right, I got 30 minutes to find this, 30 minutes to get it out, 30 minutes to reconstruct, and 30 minutes to close it. If you find like definable moments to kind of keep your plan going forward, you won't get stuck. And I've seen plenty of doctors that have been stuck and they start spinning. And for 3 hours, all of a sudden it's 3.5. And now people have problems and tourniquets and infection, obviously. So try to give yourself a schedule and stick to it. Obviously, you can cut those down and you should be able to over time, but find a point where you go, all right, here's what I'm going to do during this time. Then I'm going to move to this. Just really plan it out, the basic parts.
Great. Carl Becker, some final comments?
Yeah, I think exposure is really key. All the revisions, I do a complete synovectomy on all of them. Take the scar out. You want that knee to look just like a primary knee and feel just like a primary knee before you start cutting and putting implants back in. So those tissues should be a normal thickness. The other thing I always tell people, go see a friend. You have someone that's doing a lot of revisions, stop by, spend half a day. You can half a day, you can do 2 revisions with someone that does a lot of revisions, and you could pick up a lot of little tips from just watching someone do it. And you talk through, like, why'd you do this? Why'd you do that? And it just, sometimes just being there and seeing it being done really will help make it easier for you to get the process done.
All right, and Andrew, you want to bring us home for tonight?
Yeah, I think something big that we've harped on is trying to make it kind of easy and less stressful on yourself. So making sure that you have a good plan moving forward, even before you get to the OR. I think another big thing that I try to teach people about revisions is don't get too, overly kind of anxious about it. Once you, similar to what Scott said, there's different, steps to it. So get exposure, get your implants out. Now you've got to, basically figure out, okay, how am I going to, attach these, these implants? And after that, I mean, it's honestly, it's pretty straightforward and easy to balance these because you can put the parts where you want them. You can augment. So it's, you kind of get worried about it. I think a primary, honestly, is a little bit harder than revisions once you understand some of the different steps and different techniques. So just not getting yourself overly worked up or worried about it, and just go slow with it. And, like everybody said, just, have a plan, have your defined, kind of stages, make sure you can see what you need to, and don't get too worked up where you're going in circles. Cause I've definitely seen that with people as well. And bad things start happening the longer you're in there. So trying to be as efficient as possible.
I think all this is great advice. I going to make a couple of final comments. First of all, I want to thank Max Ortho for sponsoring tonight. A lot of people know about their new hinge, which is a low profile hinge, as well as their PCK revision system. So it was really an honor to have them here tonight. The faculty is phenomenal. Everyone who showed up, a lot of LinkedIn friends showed up, so I'm glad for that. And I want to say good night to everybody, and thank you very much for yet another wonderful evening at JOEI Open Mic Topic Session.